Greetings. Welcome. I'm very happy to see each of you here, and for those of you who are joining us online. We are in anticipation of Dr. Perez's talk tonight, but I wanted to start by talking a little bit about the Aging Initiative at the University of Arizona. I am Dr. Kathy Insel, Director of Innovations in Healthy Aging, and I want to thank you for joining us. What is the reason? Why did this even come about? Why did the Innovations in Healthy Aging and the Strategic Initiative focus on aging? Between 2030, probably between 2020 and 2030, 1 in 5 people in the US, or 20% of the nation's population, is 65 and older. The University of Arizona is in a unique position in the Southwest as a Hispanic-serving institution and a land-grant university, and it positions us to serve a diverse older adult community. University of Arizona's strengths: we have the Arizona Center on Aging and additional significant contributions in research and in education. So the goals of the Innovations in Healthy Aging Initiative were to create an age-friendly University of Arizona, and I can tell you that's a continuous process. It doesn't have a beginning and it doesn't have an end. We will always be working toward this goal. But it's part of the university's commitment to support healthy aging. We wanted to partner with developers of senior living communities and aging industry experts and offer them the expertise of the university, our faculty, and our researchers. We wanted to expand our capacity in research and discovery, which helped us. We were helped by doing that with initiative funding in order to provide seed funding for some of our early stage investigators and also those who were transitioning to a career in aging research. And we wanted to increase the workforce to meet both the opportunities and the challenges of our aging population. I am just thrilled to be able to thank the people who have been on this journey with me. Without their collaboration, cooperation, I'm not sure how well this would have gone. I am particularly indebted to Dr. Mindy Fain, who is sitting in the front row, and to Dr. Esther Sternberg, and all the members of the working team who came together from across the university to support this initiative. I want also to share with you that while you've heard a lot of talk in the news about the strategic funding going away, that we're grateful to announce our ongoing collaboration with the University of Arizona Health Sciences. We'll continue to host the lecture series, the website, and nurture the spirit of learning and wellness within our community. I've had some preliminary conversations with Dr. Fain about the Age-Friendly University global network being sponsored and moved forward through the Arizona Center on Aging. So I am very happy with that news and with the thought that what we have done will continue. And sometimes in life, you have a little bit of an upward trajectory, but there are a little bit of retractions along the way. So I want you to know that I am not discouraged. I'm very optimistic. Finally, I want to give you an opportunity to scan this QR code. This session does have DEI credit. You must complete the form if you want to receive it. The form is only active during the duration of this session, so it won't be available later. On that note, Barry should be appearing from nowhere to switch the PowerPoint. I have the most wonderful opportunity right now to introduce Dr. Linda Phillips, who will be introducing our speaker. Dr. Phillips was my mentor. She's the mentor of half of the people in this room. Your contributions to aging research, to education, I get chills up my spine thinking about it. I just am in your deep debt, and I have huge gratitude for what you have done for all of us. I could say other things. She was the Associate Dean for Research in the College of Nursing when I came on board. as a postdoc with her. She also then went to UCLA as an endowed chair and did many other additional things. Nationally, was present on both the stage, the research stage, and moving policy forward in aging, more particularly focusing on the vulnerability of some of our population of older adults. It is with deep gratitude, Dr. Phillips, I introduce you. Thank you.
Hi, good to see you all. Kathy, thank you. Thank you, yes. And it is my great pleasure to introduce Dr. Adriana Perez. And just to let you know, she was reminding us today of what a small community the gerontology community actually is. So it has been my pleasure to know her both professionally and socially, and I'm delighted to have this opportunity. Dr. Perez is currently the Anthony Buividas Term Chair in Gerontology, an Associate Professor of Nursing and Senior Fellow at the Leonard Davis Institute for Health Economics at the University of Pennsylvania School of Nursing. We'll forgive her for that because she has had all of her education here in Arizona. She is an Arizonan. Her program of research has been funded by NIH, NIA, the Alzheimer's Association. Her main focuses have been physical activity, cognitive health, cardiovascular health, and sleep among Spanish-speaking older Latinos with Alzheimer's disease and related disorders. And her passion and her research is about changing the culture of research in general and Alzheimer's disease in clinical trials so that the populations are much more inclusive than they are now. Dr. Perez is bilingual and bicultural. She is at the Center for Improving Healthcare Delivery for Aging. She is working with RICMAR at the University of Pennsylvania, which are the resource centers for minority aging research, and they've contributed an enormous amount around the country for many years. She's also served as a policy advisor of the National Association of Hispanic Nurses, and she was a congressional fellow who was supported by the Atlantic Philanthropies and Centers for Disease Control and Prevention Healthy Aging Program. And another part of her research that is so interesting is her focus on the environment and how the environment supports and enhances mobility. So Dr. Perez, we are delighted to have you.
Thank you so much, Dr. Phillips. Can you guys hear me with this mic? You can? Okay. I don't know if I should I turn this one on, please? Okay. I am just so thrilled to be here, and I want to first thank Drs. Insel, Dr. Fain, Dr. Phillips. It is a small world in gerontology, and I also had to remind them earlier that I was a student when I first met them and have known them and have really revered and looked up to them as role models in the field of aging and gerontology. So thank you so much, because the world is, circles, and so here I am back, and now I'm a faculty member, and I still see you and admire you and the work that you do and the way that you mentor students. I think it is a way that we keep our field going with mentors like yourself and myself now. Being a faculty member, I now have so much appreciation for the work that you do. So I just want to say thank you. And I also want to thank Danitza and Margaret, I don't know if she's still here, but just the team that put together the visit to the University of Arizona. Anytime that I get to come back home to the Southwest is just a pleasure and a real treat for me, because I get to spend time with my family as well. And welcome to all of you, and thank you for being here. The fact that you're here tells me that you are special because you're interested in aging. I have a sign outside my office that says, if aging is not your issue, it will soon be. And I take it a step further to say, if we're all so lucky and blessed to be able to age into those golden years, we would be lucky. Not everybody does, and that's the reason that I do the research that I do. So I'll talk more about that. And bienvenidos too. I want to make sure that those that are listening, joining through Zoom, and that are here, that I get to use, as Dr. Phillips said, my bilingual skills. I've learned through the work I'm doing that when you speak 2 languages and you practice 2 languages, it actually serves as a protective factor for your memory health. So the constant going in between two languages is very good for our brain. So I'll practice that as well. So here is a team. This is the team that I'm currently working with now at the University of Pennsylvania. They are senior researchers in the field of exercise science, sleep science, also health economics, and mentors within the School of Nursing that have a vast experience in clinical trials and community-based multi-level interventions. But here's the real team. This is the team that I work with every day. They include students, scholars, pre-doctoral fellows, postdoctoral fellows, and our statistician team, and our coordinators and managers. I am so just pleased to work with people that are new to the field, new to aging, neuroscience students that are really taking this research, making this research a part of their own, asking the critical questions, and really bringing creativity to the team. We have more community health promoters, promotoras de salud, that are part of this study. Here's just a few of them, and they are really the heart of the study. As I say, they live in the community. They are the ones that are delivering the intervention, both for the intervention and the control group. They have been part of the study from the beginning, many of them. Some of them also serve on our community advisory board. The study is funded by the National Institute on Aging, and this is a clinical trial that, which means that as part of one of the clinical trials funded by the NIA, we report monthly outcomes of our study. So you'll hear throughout my presentation, I talk about accountability as researchers, not just to be able to make sure that our populations are inclusive, but that we are reflecting that in the way we recruit and our outcomes in recruitment and retention. So we publish this every day. The study is available through the National Library of Medicine as a part of being transparent on what is funded, what the work entails. So it is available in the public domain. I've been studying physical activity for a long time. I'm a nurse practitioner. I have been a nurse for more than 20 years. And what I know from listening to older people is that physical activity is very important to us as we age, and especially as you are older. It means so much to be able to move from one place to the other. Sometimes that means being able to walk from here to the mailbox without getting short of breath. Mobility in general, movement, is so important to older people. And every time I ask them, if you could give advice to young people growing up, young adults, what would you tell them? And they always say the same thing. The majority of the time they say, I would tell them to keep moving. Take the stairs, don't take the elevator. As much as you can, just keep moving. And they always look back and say, I wish I would have moved more. Now that I'm older and I want to do more, I'm limited. So I'm studying an area that I know is important to patients and the community that I serve as a researcher. There is growing evidence of the impact of physical activity on brain health. We know that physical activity is good for heart health, and that's how I started my research. But we know now that what is good for the heart is good for the brain. So things like movement, the things we eat, all of the risk factors that lead to cardiovascular disease also put us at risk for losing memory over time. Unfortunately, cognitive health, up until now, and there is hope on the horizon that there is a cure, but for now, it's considered a progressive disease, meaning that slowly the person will continue to see deterioration in their cognitive health. In the Hispanic Latinx community, very little clinical trials include Hispanic Latinx people, even though we are 1.5 times more likely to have cognitive decline. We are less than 3% of clinical trial participants. And so less than 3% when you consider the fact that as a population, we will see one of the highest increases of Alzheimer's disease. We're expected to see an increase of 800% in the next 20 years, and for many, many reasons. And as I said, there are many barriers that are in place that prevent us from seeing this significant advances, scientific advances in the discovery of brain health when it comes to Hispanic Latinx people. Few physical activity interventions are designed with the community and even less so for the community. Most clinical trials require people to speak English. So that is a major barrier. And as Dr. Phillips said, I'm part of a national coalition of scientists, of clinicians. They're trying to change the culture of the way clinical trials are conducted. And so the work that I've done has really brought me to where I am now, which is in designing multi-level interventions that promote physical activity in this population. And what does that mean? Well, it means that I know as a practitioner that it is not enough to focus just on the person when you are trying to promote health. You have to understand their environment in which they live and how that environment either puts them at a position to be able to be active or prevents them from being active. And I also have learned throughout this time that that in itself is also not enough, that we need change at the policy level, at the neighborhood, community level, and through issues related to the environment, climate. Those are things that are also important and keep us in a condition to be healthy and to choose physical activity as the default. So this intervention, and I'll describe it a little more, it does include all of those levels of interaction, and we follow those individual outcomes, interpersonal outcomes, community outcomes over time. When I first moved to Philadelphia almost 8 years ago, I knew it would be important for me to embed myself in the community, get to know the leaders, get to know the organizations, of course, my colleagues, other clinicians, other providers that practice, where the majority of older Hispanic Latinos live in Philadelphia, and get to know their work, know the issues of the day, as well as get to spend a lot of time with older people through community centers, art centers, coalitions. I was soon recruited to be a member of the Latino Golden Age Coalition when I moved to Philadelphia. And they recruited me because of my background in research and clinical practice. People in the community really value researchers. They feel like we can contribute something that would be helpful for them in the form of data or in the form of putting together stories, whether it's qualitative research, quantitative research. They value scientists, and for the most part, they trust science. They might have had a bad experience being in research, and I want to change that, but they do trust scientific advancements, and they want to be part of it. In the preliminary work that I did with colleagues, we found that through community-based focus groups, people talked about memory and sleep as two of the most important health outcomes for them and their families, particularly memory health. And I would often hear, the stories of I might not have a huge fortune, I might not have a lot of money, but the memories that I have and that I could pass on to my grandkids, my children, and the next generations are the legacy I plan to leave behind. The stories, the history. There is rich history in the northern part of Philadelphia that really deals a lot with the migration of Puerto Rican families from decades ago. Just like we see now, people migrating to the US, the same thing there because of economic issues and because of staying together with family. They talked about, though, the environment and how where they live really prevents them from being active. They talked about safety concerns, about not having enough safe places for walking, but yet being very interested in being more active, being able to move with their family, move with their friends. So some of the additional work, understanding what was important to them and understanding, again, that the environment was important. By the way, that was the same thing I found in Central Phoenix when I was here as a student, that here I am as a nurse practitioner telling patients, telling participants, you have to get 30 minutes a day, you have to get 150 minutes of activity a week, not knowing what they dealt with in terms of the walkability of their neighborhood, where they have to walk was very important. And when I understood that, then I was able to be a better problem solver, be a better provider, a better researcher. And so through GIS mapping and collaborations within our school, we used this to look at community level factors, look at things like socioeconomic status, crime rates, and also an opportunity for walking. I learned early on from mentors that it's important to look at the challenges, the problems, but also the opportunities and the strengths that are inherent within any neighborhood. So I'll share a few maps. Through GIS mapping, here is Philadelphia. The green part is sort of in the outer Philadelphia region, and what you're seeing where all the black dots are, the black pins, those are our research participants that were in our preliminary work. So the majority, the green is showing where the majority of our white participants live. The blue is North Philadelphia, and that's where the blue signifies where the majority of the Hispanic Latinx community lives. The gray area includes parts of West Philly, which is where I live. I live at the campus of the University of Pennsylvania, and you see that that is where the Black or African American community lives. The darker the areas that you see, the higher the crime index that is experienced by the people that live there. And it is true, North Philadelphia and West Philadelphia see some of the highest crime rates in the country, particularly North Philadelphia, and we used information from the FBI crime statistics that show that here is where things like murder, armed robbery, and really high-level crime, this is where the majority of it takes place. So it validates what people told us in the beginning, that they don't always feel comfortable going outside to walk. They are always thinking about this. This is at top of mind. Some of them want to walk with their grandchildren or their or younger family members, and this is something that worries them. Also interested in looking at socioeconomic status, and so here you see kind of the same trend that the higher, the darkest red areas is where the lower median housing value is found, so higher poverty rates. And it is the same trend if I show you the maps for population density, so more people live in these areas. And interestingly, two things that we're looking at are noise level and light activity. So the same thing, noise level includes things like people walking outside, talking, parties, but also noise that is captured from above. So airplane, they have the Amtrak that goes right over the neighborhood where we're doing research. So there's very high noise level that people always have to deal with. And it really explained a lot in terms of what we were seeing in their sleep activity, just based on the noise level alone, and the activity that we were seeing both on their ActiWatch and through this GIS mapping. So as I said, it was important for me to also get to know the leaders in the community and the people that really are, their whole mission is to be action-oriented. So this is community-based participatory action research. A lot of the leaders that you see around this table represent nonprofits, represent faith-based organizations, businesses, educators, people that provide legal services for Latino communities. And they have been a coalition for more than 20 years. And every year they work together to put on an annual conference for older Latinos, all in Spanish. It includes different promotion of awareness, education, and bringing together resources in the community. I was so inspired getting to meet them and know them because they are really aligned with what I see, and that is not just coming in and describing the issue, the problem, the research question, but really working together to address how to solve those problems. And they just get the work done. And so they became pretty much my best friends in Philadelphia and who I consider my community there. These are the specific aims of the study. So the study is called Tiempo Juntos por Nuestra Salud, Time Together for Our Health. We had to pick a name that would mean something to both the control group, the education group, and the intervention group. We were talking about this earlier, Dr. Insel, we were talking about that it's important that the control group also benefits. And we are seeing, we have not gone through the analysis, but I'm going to be very interested in seeing this. There is a lot of research coming out now that if we continue to learn throughout our life, that meaning that we don't stop learning after high school or college, that we continue to learn throughout life, that also helps to protect memory and serves to promote cognitive health. So we will see, because just based on satisfaction scores, the control group rated very highly the education sessions that they had. So our primary outcome is physical activity, non-pharmacologic intervention to promote cognitive health, sleep health, and heart health. Secondary outcomes are those health outcomes. And then I'm very interested in learning why things work, right? So the theoretical mechanism for change, looking at the individual level motivation, goal setting, ensuring that every person, designs their own goal and is able to self-regulate and self-monitor throughout the time, as well as social support and environmental health or community-based resources to promote physical activity. We're very interested, there's a lot of research, as I said, that growing research looking at the impact of physical activity. We're also interested in the impact of cardiovascular health and sleep quality on the effect of cognition. One of the early signs of cognitive decline, especially in this population, is the language aspect. People begin to forget words. That when you're studying cognitive health, there are many dimensions of cognitive health that we look at: executive function, episodic memory, working memory. Well, many of those tools were tested and even translated among people that are highly educated. And the majority of these tools are tested in Mexican-American people and Spain. I think those were the top two. But they haven't been tested in people from the Dominican Republic, Colombia, Puerto Rico. There's a lot less there. And I know, now living in Philly, that there are subcultural differences and even language differences that are important to note. And what I'm seeing too in the literature, and sort of validated by these findings, is that we're seeing higher cognitive decline in people from Puerto Rico, those with Afro-Latino roots, than we are seeing in Mexican and Mexican-American people. And I don't know if it has something to do with geography, the way in which the communities we live are, but there is something there. And then finally, the National Institute on Aging, for any intervention, they want to look at cost. They want to look at intervention cost, and here we're comparing intervention cost to healthcare utilization. And so I'll share some, so far, interesting findings that when I think about the study here that I did, there are some definite differences in the populations. So basically, this is the framework, and I'll just draw your attention to the theoretical mediating process, because when I talk about this, I say, here's the secret sauce, What makes this work is that we get to know people at the individual level. We evaluate a person's self-knowledge, their index for readiness, their readiness to begin a physical activity program, and self-regulation over time. We look at interpersonal factors, their social support. Do they have people to walk with? And through the intervention, that's what we try to build, as well as build community resources for physical activity. So our hypothesis is that if we see an improvement, an increase in motivation, we will see an increase in physical activity captured through hip-worn accelerometers, and then we should see improvement in health outcomes, cardiovascular health, cognitive function, and sleep quality. And sleep quality, the same thing. We are looking at several dimensions of sleep, not just total hours of sleep, but sleep efficiency, wake after sleep onset. So, this was one of the reasons why a lot of people joined. They always say they're having trouble sleeping. And that's another sort of sign when people are experiencing memory problems. They start to experience problems with sleep. And they would say things like, I go to sleep, but I can't fall asleep, or I'll wake back up and I can't go back to sleep. And very interesting, the number of times they wake up during the night is compared to what is considered normal. It's normal that we might get up 2 or 3 times during the night, but on average, these participants move anywhere from 30 to 33 times at night. So they're not getting rest. And so that's a big issue. So this is just translated to Spanish. We have it there. The design of the study, as I said, this is a clinical trial. So participants are randomized to either the physical activity group, which meets twice a week for an hour each time for 12 weeks. The education group meets for the same time, so they have the same time and attention, but they receive health education based on recommendations of the older adults in our preliminary work. They pick the topics that were important to them, and that's what they learn. And again, we've had some very positive outcomes there just based on satisfaction. Over time, we're doing repeated measures, analysis of variance, following individual level change as well as group change over time. And the participants in the study understand that what we ask of them is a lot. We follow them for a year, every time point at baseline, 3 months, 6 months, and at the year. The period of evaluation lasts 2 weeks because they wear the watch and they wear the hip device for 2 weeks to give us a good indication of their normal healthy patterns, their physical activity and sleep patterns. And here is an example of just inside a senior center where we walked. I was sharing earlier that inclusion-exclusion criteria is so important. And we started out with a list of people we were going to exclude. And gratefully, we have an expert, physical activity consultant. He said, if you exclude people that have arthritis or that use a cane to walk or a walker, you're going to exclude the majority of the people, because all older adults, and I think, yes, all patients that I see use an assistive device. And he said, there's really no reason to exclude them. If you do a safety assessment, which really is required in physical activity research, that is just to tell you what kinds of adjustments you have to make to any kind of activity. But do not use it to exclude people, because you want people that are sedentary to increase their activity at any level. That alone is progress. So I'm very glad that we had him on board. We listened. We also had to adjust our cognitive scoring to follow a protocol that also takes into consideration not just did the person not finish high school, but did the person even go to school? We have a lot of participants that never went to school, signed their name by an X and talked about that, said, in my country, I wasn't allowed to go to school. So it wasn't until later, that I learned some things, but I never learned to read or write. But yet these are people that take care of their grandkids, and are very self-sufficient. They drive, they navigate the community, the resources that they have. So we're looking at cognitive health more holistically, not just looking at a score, but also taking into account what the person can do for themselves and for their family, and come up with sort of a more holistic score that we think is more indicative of this person's cognitive health, more reflective. And as I said, there is no gold standard for the measures that are currently available to us. They all have challenges and they all have, some positive aspects, but there's no one that is the best right now. And we're trying to develop that too for our study. And we think it's going to be a great contribution. In terms of procedures, just an example here of what we talk about with participants. We do ensure that they understand the commitment that it's a year, every 3 months. At any time they can withdraw. They do get a $50 gift card at every time point. But they do understand this. And we have, I don't have it here, but we have a list of reasons. Like, our recruitment was great, but our retention was even better. And the reason why people would withdraw would be because they lost a loved one, they had to move, their health or somebody's health. I mean, the reasons why they might have withdrawn, or they didn't come to an intervention session, their car was stolen, or somebody, they experienced some kind of violence out in the community. I mean, reasons that we realized early on, we need to track these reasons to show the complexity and the life challenges that older Latinos in the community face. The intervention was, as I said, led by Promotoras de Salud and tailored to the individual's capacity, meaning that you could walk at your own pace. We had many older adults that use a walker or use a cane, and they could walk at their own pace, and we had some that were a little bit more advanced and could walk, at their own pace. And between the community health promoter and somebody on the research team. Now the study is blinded, meaning that those that were involved in the intervention or education sessions were not the same people doing the evaluation. That was very important, but there was always someone who the person can walk with. And over time, building social support was important so they could walk with either the promotora that lives in their neighborhood or the people at the community site where we were conducting these sessions. Manualized procedures, everything we have is both in English and Spanish. The Spanish translations were not just because they were already translated, but when I got to Philadelphia and build these partnerships, we also had them translated for cultural equivalency. And one of the measures, for example, that we have on environment, an example that I give is I'm Mexican, and so here in the Southwest, for sidewalk, we say banqueta. Over there, they say acero. So if I kept that on, some of them would be confused, and they really helped to translate to a way that the majority can understand. And that was very important to show that attention to detail. Ensuring that the intervention is delivered consistently and following our protocol. We have a stretching protocol from head to toe, and there are certain songs that we use when we're walking inside, and they all sort of, to the same beat. So intervention is pretty much conducted pretty much consistently. And I want to share our progress in how well we did with recruitment. The fact that this study was led by a community advisory board from beginning to end. I remember the first time we submitted the grant and it didn't get funded through the National Institute of Minority Health. They really are the community that sort of built, I felt, me up as a scientist and said, what do we have to do? What do we have to do to get funded? And let's do that. What did the review say? Just very, people inherently strong, and people that are inherently resilient that we can learn a lot from as scientists. And because of them, our recruitment was great. So the red line signifies our actual enrollment, and the blue line is our target enrollment. The target enrollment is what's reported to the National Institute on Aging clinical trials. So every month when we report, this is what they see. How are you doing every month with recruitment? And towards the end, especially, when we really had a solid team to take us through, we exceeded not just the goal of 216, we recruited 236 participants, but we exceeded our time by 5 months. And that is unheard of in aging research. Most of my colleagues are asking for extra time or writing reports of, what will we do to improve our recruitment? We did not have that problem. Actually, our problem was quite the opposite. We did not have enough equipment and personnel to be able to conduct the study, the evaluations, which take up a lot of time. And honestly, I have to say, because we are in an academic setting, academic institutions don't make it very easy to work and hire people from the community. Challenge after challenge in trying to hire people from the community, in trying to pay participants, that I was just not willing to give up. Stayed on top of it, but those were the barriers that exist. And I understand, being an academic, I understand why those procedures are in place, but it really made it very difficult. This is our consort flow diagram. At the very top, I think for reporting recruitment and retention, it's important to also, in community-based research, to report the work you are doing for promoting awareness of the opportunity to participate in a clinical trial. So if you look at the very top, We talked to over 300 people that might qualify for the study at various events, at various organizations. You could see there, the next box shows who was interested, who was consented, and who was not interested. And then look at the next box and who actually was eligible to participate, those that were not randomized and those that were randomized, and then the two arms there. That's where we are now in the follow-up phase. So we don't have a lot of analysis. We have some preliminary analysis that characterizes the population that is in the study, and when we're doing a lot of follow-up now. So just a little bit about our sample. A few years ago, there was an article in the Philadelphia Inquirer. It was in Spanish, but it was called Where Are the Latino Men in North Philadelphia? And they shared that the statistics for the older adult population was something like 75% women, 25% men. And indeed, that is exactly the population, in the senior centers and where we recruited. So you see here that the majority are women, and the mean age is about 72, and 56 to 86 is a range. Inclusion criteria included 55 and older, mainly because of how we start to see cognitive decline in this population. Really, we see it at a younger age. So this was part of the inclusion criteria that I had to give a rationale for, because usually it's 60, 65. Also, at 55, you'll see the majority of participants were dual eligible, meaning that they qualified both for Medicare and Medicaid. So that was a large part of our population. But the majority are widowed. The majority did not finish school, high school. We did have, and this was important to note, we do have participants with a master's degree from their country, so highly educated. And they often would send us back flyers or things we gave them that were written and said, you misspelled this, or this is wrong, and we took all that, thank you so much for looking. So it's important also not to put everybody in a box and just figure everybody, poorly educated. We had some educated people, and as my mom says, it's not so much about formal education, but the education in which and how people, conduct themselves, that you would never know that because of how people are. And so, as you can imagine, the majority retired or unemployed, and in terms of economic status, living below the poverty level. And the majority are Puerto Rican, but growing number from the Dominican Republic, Colombia, and other countries. Very few Mexican-American people, and again, most of the younger Hispanic, Latinx population in Philadelphia is in South Philly and in the surrounding area and the mushroom farms, so outside of the Philadelphia area. In terms of health insurance coverage, I included this because this is very different from when I was here and the community I worked with. The community I worked with then, the average age was about 60, so not yet qualified for Medicare. The majority were Mexican, and the majority had no health insurance coverage, which is why they were in a study, just to have access to a provider, to focus on health promotion, and the opportunity to talk to, someone like a nurse, to a researcher, was a big plus. And I think the same thing we found here, the participants really appreciate being able to talk to researchers, clinicians, and that was a motivating factor for joining this study. But again, at least I think this is a positive, that everyone in the study has access to health insurance in some way, whether it's private, they all have access to health insurance, so that was a plus. Through the Community Advisory Board, it was important early on that we understood the subcultural and linguistic differences that would impact the assessments, the cognitive assessments, not just in the responses, but in the way these were conducted. Most of the people that tested our procedures, whether it was the community health promoters or advisory board, told us that these were intimidating. And the fact that we use things like test, and they might think, did I fail the test? Did I pass the test? Those words are intimidating. They said, so to think about how we were presenting these assessments, and the language differences, as I said earlier. We have students that are also very diverse from the Dominican Republic and other countries that also helped us through this, really provided their experience and their expertise as students, and gave us feedback before we went out and started recruiting. And as I said, we pilot tested all of our procedures before we started. And an example of cultural language variation or subcultural difference here, there's a question on one of the cognitive assessments that asks participants to list all the vegetables they can in 1 minute. And many, we started noticing, would list a guineo, plátano. And so you might think that's a fruit. In Mexico, it's eaten as a fruit, but in other places, Latin American countries, it is a vegetable. So pretty much the approach that we took here is in things like this, we would accept what they said because if that's what they felt, here, that's how they eat a banana, then, we added that as their point. Religious preference was important too, because we often see in research that one way to retain participants is to send them birthday cards, send them holiday cards. Well, while the majority of our participants are Catholic, and that's consistent with the rest of the Hispanic Latinx community across the country, there is a growing number and a good number that are not and don't practice or don't, they don't celebrate birthdays, they don't celebrate holidays. And I was actually told by one of the participants, I know what you're trying to do. She was very kind, and said, I received your card for my birthday, but I don't celebrate birthdays. She said, in my religion, we don't celebrate that, and it's important for me that you know that. So we started collecting this information, and it really helped us to individualize our retention. So I asked her, I said, how can we acknowledge that you are in the study and that we appreciate you? And she said, because we get to know them for the year, so she said, send me a card whenever and just let me know you're thinking of me. So they really appreciate that. And then secondly, I knew that el 10 de mayo is Día de las Madres in Mexico. Here in the US, Mother's Day is the second Sunday of May. But in other Latin American countries, look at how different it is. And we do have this representation in our study, even if it's 3 or 4 participants. We know that, and they get their card at that time, and they just think they get such a kick out of this, that we know this, and that we've taken the time to acknowledge this. And actually, all the participants, the majority, when they saw this list, they said, I didn't know that, this is good to know. So really helped us to improve our retention. Where we are now, I was sharing with the group earlier that our advisory board told us when we shared, patting ourselves on the back, how great we're doing with recruitment. They said, yes, but all the people you're recruiting are older people that are out in the community already. They're out at these centers. They know how to get help. What about those that are isolated at home? Indeed, there's been research out of AARP and others that have looked at isolation in the era of COVID and loneliness. And they said, we're worried about those that are in their home, that want to participate, but don't have the way to get out. And so thanks to our awesome students, they created a social media campaign and recruited using Facebook. Facebook was recommended as the mechanism which more older Hispanic Latinos use, and indeed it was great. We were not expecting to have such a good outcome and interest. And what we learned is that if you don't get back to people within 2 weeks of them expressing interest, you lose them. We tried, reaching back some that were very active on our social media page, our Facebook page. We lost them, and so we figured that out, and we ended up getting about 20 people. 10, they were all randomized, and they're right now finishing their evaluation. They love Zoom. If we were to present Zoom to the people, which we did, actually the people in the senior centers, they all said, no, I don't want to use Zoom. I want to be in person. I want to come here. I want to see people. They don't like it and they don't want it. But these were younger, older people in their 60s, the majority of them. The majority of them have had some kind of injury by which they could not keep working. So they have other interesting findings, and we're very happy to have them. They've informed all of our procedures now, but Facebook was a great and inexpensive way to test messaging and to recruit diverse people within our diverse sample, and be interested to look at that. Students took that project and ran with it. One of them created a poster based on those efforts. She came up with an analysis of cost, and on and on and on. So a couple of final slides here of where we are, and I'm happy to answer your questions. It is very important, not just for me as a researcher, but for the study team and the community advisory board, that participants have a positive experience in this clinical trial. And what we know is that many times, people are in research, they don't really know what happens. And as researchers, we also have to follow, rigorous protocols too. And they all know that they will get their results when the entire study is done. Giving them results earlier could impact the integrity of the study, so they understand that. And right now, the study team is creating what are going to be participant files. Each of them is going to get a file with all of their study results, but we're presenting this in a way that they can understand. So not just the numbers, but what do the numbers mean, right? So here they're going to get their blood pressure over the period of the year, both on their right and left arm. And then at the bottom, you see the categories of blood pressure, what is normal, what is high, what is borderline. So they will get this along with a session, a one-on-one session with the study team that will walk them through the results and explain what was your blood pressure, what was your sleep, what was your memory health. So we have one like this for every one of those outcomes, and with a cover page, and we encourage them to share it with their primary care. We actually had that in our pilot when we were testing procedures, and I had a woman who said, I shared that with my doctor, with my primary care doctor, and he was so proud of me, and he told me, keep going, keep getting involved in research. And he took the copy and kept it in my file. So that's something that we share. Share it with your provider. This just gives them another piece of information about you, and share it with your family. What we're planning on is that when we get back to them with these results and schedule times, that we will ask them then to bring somebody in their family if they want to, because adult children, for especially older Latinos, they care a lot about this. They want to be there. They want to know, or we'll get calls. We want to know what my mother was told. So we want to do that at the beginning so that they know they're welcome to come as well. And then lastly, I love research. And as I mentioned earlier, looking up here to leaders in our field that have served as great mentors. I'm now so pleased to be able to mentor what we consider the next generation of scientists in aging. And this study is a community-based study that gives students an opportunity for real-world experiences. And I tell them, older people love to talk. Many of them do know Spanish, but don't really speak it. They're in school, they've been in school. So here's an opportunity to practice your Spanish. Whether you're talking to an older person or writing them a card, here's an opportunity. And we get a lot of students from the neuroscience school, they're studying neuroscience, and nursing students, as well as students across the university that are interested in health and in aging. So again, a positive experience. You see students walking here in one of the communities of North Philly, and the participant that came out because she saw their shirts and she was wearing her shirt and she recognized it, so wanted to say hello and wanted to welcome them into the neighborhood. So just a positive experience, an experience where they also contribute. You've heard the ways in which they helped improve our social media campaign, and an opportunity for them to learn from the communities themselves. I tell them, what you're learning here in school at the University of Pennsylvania is so important, but what you're going to learn out in the community is something you'll never forget. And indeed, they have a positive experience. They get to see the strengths of the community as well. And I will say this, I'm not saying it's easy, but I will say it's fun. For those of us that study aging, it's fun. You have a lot of fun, especially when you get to see people and meet them wherever they are. I wanted to make sure we included our Facebook, our website, our email, and information just about our marketing, and the logo that was designed by a community member. You might recognize that in Spanish, se llama El Rielete. It's like a little fan that's moving, showing us action towards positive health, the colors that are vibrant, of course, the purple reflecting memory health, and the name that I think working with the community is a name that they all recognize and a logo that they recognize. Notice how Penn is not part of the logo. And that was purposeful because we really felt like this is from and within the community. Of course, Penn is a support, that's where I work, but it really is a community-based study. That's it. Thank you. Yes, questions?
I'm Kareem, and you mentioned earlier on the section about using social media to reach out to more isolated older adults, how it was very effective on getting a lot of 65-year-olds and people around that range. Do you have any ideas or maybe thoughts of how we may be able to reach isolated adults that are maybe over 75? Because I think social media, like the usage of social media, it kind of declines the older you are. So is there any ideas of how we can use that to get even more of a range of ages for that?
Yeah, so we were talking earlier about this, and something that we found so helpful was to focus the efforts on the younger person in the household, whether it's grandchildren, younger children, because we have found that they care so much about their grandparents, and that relationship that older and younger, that the grandparent and grandchild have is so powerful. And often, I'm sure some of you might see this in your families, what grandparents pay attention to the kids, whether it's adult kids or younger kids, and they tend to go and use their help for figuring out social media, for figuring out technology. We had just started that recruitment and testing that campaign, but we think that that is a way to reach even older people. It just so happened to be that the 20 people that we recruited now, when we look at their average age, it is about 65, maybe a little less. But if we think that if we continue to work on this, we would see also a change and be able to recruit older adults. The problem that we ran into, because after the first 3 months that they participate, we then follow them through mobile health technology, whether it's phone calls or text messaging, is that many did not want to use their phone. They did not want to text. They did not want to be on the phone. They wanted to be in person and really really stuck to that. They couldn't hear their messaging, whether it was some alert, they couldn't hear it, they can't see. So all of these challenges that are pretty common for older adults we saw. And so that I think is going to be the biggest challenges. I already know in reporting that that's probably where we'll see what we find, but we did have a lot of issues with technology, and I would love in the next study to work with experts in technology that really understand and could really help us improve that aspect of the study. That's where I think technology could really be the bridge for inequities. Right now, things are designed not really thinking about minoritized populations, but I think it really could help bring people along and really serve for good. And that's what I look forward to. So if anybody here has any technology experience, and looking for collaborations, I think that's something that will be important moving forward.
Thank you.
Mm-hmm. Great question. Yes, Danisa?
We do have one online. Did you do any studies with cancer in the Hispanic community, emphasizing on getting the proper health care and not waiting until it's too late?
I'm so glad somebody asked about that. We did not, but what we found as I said, people are in the study for a year. We lost 4 participants that passed away. 3 of them were to cancer. And we knew that they had cancer, but the cancer they had would not prevent them from participating in this kind of trial. This study was considered so low risk through IRB, so we knew that they could participate. And so now when I think about that, and the need for cancer resources and what I see, especially at the end when we lost these participants, how much they could have benefited from that. But no, so they were included, but we did not address cancer. So important, though. Any other questions? Yes.
Hello, my name is Luis Ceballos. This is more of a personal question. Spending many years in Philadelphia, working heavily with the Latino X community, especially the older population. What fulfilled you the most, and what brought you the most enjoyment?
Oh, so much. You know, people, when I left here, my friends, colleagues said, "Why are you moving to Philadelphia? There are no Latinos there. There are no Mexican people there." And I learned, because I did my research, I did my work before I moved there, that Pennsylvania is one of the top 10 states for Latino growth. And so I wanted to study that. I wanted to learn that. It was a prime state to learn about that growth. And it has been while I've been there. And I must say that, especially the leaders that I met within the advisory board community and even beyond that, their reverence for older people and the way they take care of they take care of themselves. When COVID hit, I was volunteering to translate anything, to get information out, to get to see older people that were isolated, because I was also practicing in North Philly. I really got to see the resilience and the strength that the community has, where I don't even think it's fair that we count on that resilience and strength. Like, we shouldn't make it so hard, Yes, they're resilient, but sometimes I used to think that was a positive when people told me, "You're so resilient." And now I think, I wish I didn't have to be. Like, I wish we all just had an environment where we didn't have to work, and in this case, things are so hard, and I mentioned some of the challenges that they have, and that they experience that daily, but yet they go on and they, being in the study, the majority are looking forward to their results. They're very proud to have been in a study, to be part of a clinical trial, and the way they talk about it, and the way they come up with resolving the issues, the day-to-day issues, and still being there for younger people. I mean, I'm so inspired by the community that when people ask me why I'm still there or why I moved, I say there's just, the community itself is a major inspiration. It served as a support for me when I first moved there, going through the tenure process. They were my strength. The students too, I always say the students and the community are, tied, but I would say the older adults a little bit more, just because I'm also a clinician and I see them. And so to bring them together, bring students together to see them and see how much they enjoyed working with them. And I keep in touch with many of them that will say to me now they're applying to med school, they want to, study aging. That is, as you said, what has brought you the most joy? I think that has brought me the most joy, is really getting to see being in between these two generations of students in college and older people. Thank you. What a great question. Is your mentor Dr. Fain? Yeah, so I can tell you have great mentors because these are great questions. Yes.
Hi, my name is Armando. So I had a question more pertaining to, I guess, the future and your thoughts on it. In my personal opinion, we live in a very ageist world with very limited access to even basic things like sidewalks, as you mentioned beforehand, and that prevent mobility. Do you have any thoughts or ideas as to how, because it seems like more like a system problem, as to how those can be resolved in the future?
Yes. See, brilliant questions from students and our future workforce. Exactly. All the isms that we're looking at now. I think ageism is the one that has been widely accepted in our society, especially here. In other countries, and part of my growing up was in Mexico, and it's very different, in how we treat older people. And so coming here, it is kind of a culture shock in how older people are treated, how they're talked to. And when I was first a nursing student, I remember that the positive experiences I had made me want to be in this field, because they were positive experience, and I got to see people healthy, not just in the nursing home. The nursing home is important, but people that when you ask them, they don't, "Oh, I'm not old. Oh, I qualify for your study," very shocking. And they might have a list of chronic conditions, But when you ask them how they are, how they're doing, oh, I'm fine. Oh, yes, I have this problem, but I'm healthy overall. And so we are, and you were spot on that the communities in which older people live, in this case, not a lot of places for safe walking, because I study things like sidewalks and the space between walking and traffic. I mean, that's right there. That's something that I think doesn't require a whole lot of change, just the support and obviously the funding, the structural change, that if more people took this on and really galvanized the community to be able to make change, I think we could see that more. But there's no political will sometimes to make these changes. We're in even medical research, we're always treating disease instead of really focus on promoting health. And so that's why I'm very glad that we're looking at cost and cost effectiveness, because we are going to see that over time, it's not that we don't want people to use healthcare, they should be using their healthcare, but will those visits to the emergency decrease, what does that utilization look like? And actually for both groups, when they get an orientation to the study, we talk about those things. We talk about what it means to be in a clinical trial, what it means to be randomized, and they learn so much through that process. And I do wish that there were more efforts to address ageism in this country on both sides, because young people deal with ageism too. And I saw that when I was in policy. I spent 2 years on Capitol Hill, and a lot of the young people that work there see that every day, the way they're treated. The staffers, they're the ones that do all the work, but because they're young, they're treated differently. And so ageism doesn't help anyone. Thank you for that question.
Thank you.
I just want to thank you so much, Dr. Perez. That was
Thank
a
you.
very inspiring talk and gives us all kinds of future possibilities. And also thank you for coming out, and for those of you online. Thanks for being here.
Thank you so much. I do want to thank my husband, who's right here, came to the presentation. He has been such a supportive partner in this work, so thank you.